Good morning and welcome to the Advances in Ophthalmology Conference. We've had 3 fantastic introductions already, and so I'm going to get straight into the first session that we have for today. We're firstly going to be talking about sustainability and innovation. Now, some of our speakers are live, some of them are pre-recorded, and even the pre-recorded ones, some of our speakers are going to be available to answer your questions. Now, we have a bit of a time lag between what we as the speakers are seeing and what you as the conference attendees are speaking. So it's best if you can please write your questions in the chat, and that way we'll have them immediately available for when we start any Q&A sessions if available. But a lot of our speakers will be answering directly online as we go through. So without further ado, I would like to welcome Dr. Jesse Gale. He's the chair of our new Sustainability Committee for RANZCO, and he's going to speak further on this topic of sustainability. Thank you so much.
Tēnā koutou katoa, Jesse Gale here, speaking to you from my home in Wellington. I'd like to acknowledge the tino rangatiratanga of the tangata whenua here and the traditional owners of the land where you are. Thanks to the organisers for the invitation to present and discuss some of the ideas that our Sustainability Committee has been working on. I'd really welcome some interaction with you at the end of this session. Our committee often discusses what we mean by sustainability. There are various environmental concerns that we might worry about, and there are other meanings of sustainability for RANZCO, like ensuring the sustainability of our organisation and building a sustainable ophthalmology workforce to meet the population needs. But mostly our committee's activities are about climate change, because this is the existential threat to our environment, and addressing climate change will have co-benefits to other environmental issues and co-benefits to other social and health issues that we care about. So this talk is about the role of medical colleges and RANZCO in climate and sustainability, and then about the process of starting to reduce emissions from ophthalmology. I wanted to add a word about mandate. We did surveys of our RANZCO fellows and trainees and found that, yes, ophthalmologists care about climate change, not as much as random members of the public do, but there are younger ophthalmologists coming through who worry about climate at least as much as other people in the supermarket. There is majority support for the idea that RANZCO should have a voice on climate and health, and that our main focus should be on reducing emissions from our own work in the health system. So on the role of colleges here, there was a useful survey of medical colleges done in the UK, laying out their plans around sustainability in 2014. So we repeated this project this year with a student, asking medical colleges in Australia and New Zealand what they're up to. And this highlighted 3 main areas, which I'll go through here. Corporate responsibility refers to the sustainability of our RANZCO office activities. So this means footprinting and demonstrating reductions in our emissions. Most colleges have improved a lot with the pandemic. Responsible building means using low energy lighting and heating, insulation, and appropriate building materials rather than rainforests and high carbon concrete. Zoom meetings and hybrid conferences, of course, and then divesting from polluting industries, which is an important ethical step, even if it doesn't change market behaviour. And on all of these things, I think we can be proud of our college RANZCO. We're doing reasonably well. There are increasing calls for doctors to have a voice on climate because we're influential, relatively powerful members of society. And this, of course, includes taking responsibility for the emissions produced by the health system. And so RANZCO is the professional voice for ophthalmologists. And there's this hierarchy of domains, and climate action is required at every level, and then a corresponding hierarchy of medical organisations that act at these different levels. And there are also some alliances across health, and recently alliances between colleges. RANZCO joined a project led by the College of Physicians to describe the effects of climate on the health system in Australia, and this led to the Healthy Climate Futures campaign, which was a national political campaign calling for a health system that's both climate ready in terms of climate adaptation and climate friendly, which is to say reducing emissions, decarbonising. RANZCO also is starting discussions with our ophthalmic industry partners and has also advocated at a regional level on energy infrastructure. Our sustainable practice guidelines also support clinicians to advocate in their own hospitals and networks. And then the third major action for a college like RANZCO is connecting with trainees and fellows and offering support and resources. This is where colleges have a practical advantage over pan-professional and political organisations like the AMA, who have less direct connection with clinical practice. And so the second part of the talk is about the details of reducing emissions from ophthalmology. This diagram from the British NHS emphasises how most of the healthcare footprint is from energy for heating and lighting and running machines in our hospitals, and from transport of materials, but also people. You can see they're also quite worried about these nasty gases that are released by retinal surgeons. Anyway, it's a bit different when we measure the footprint of ophthalmology because procurement seems to play a bigger role than energy and transport. In our cataract footprinting project in Wellington, the number 152 was similar to 6 days of life in New Zealand. And I think only registrars take 6 days to do a cataract operation. So that indicates that cataract surgery is a very resource-intensive activity. The other takeaways were that transport is significant, but smaller than the others. Energy emissions come from coal or gas heating of the hospital and electricity use. So in countries with old hospital boilers or in an energy grid which is powered by fossil fuels, the emissions from building energy are more significant. The other obvious thing here is that India has already solved this through the reuse of many instruments and countless other efficiencies in their systems. I like to say it's interesting to reflect on the barriers that prevent ophthalmologists here from immediately practicing like our Indian colleagues, because we could save large amounts of money in carbon, and yet we don't. But the main source of emissions is procurement. And I think these pictures will be familiar. We all open these many double-wrapped products at the start of a case, and the packaging immediately goes in the bin, maybe in the recycling bin, followed by the product itself 10 minutes later when the case is finished, leaving a whole bag of rubbish for every case. Our committee member Michael Loughnane made this video simulating the amount of waste produced by his surgery, and apart from feeling jealous of him doing so much surgery, it's a compelling illustration of how it all piles up. It's the production and supply of all the single-use stuff that drives the high emissions from ophthalmology. When it comes to intravitreal injections, the setup and delivery of injections use much less resource than cataract surgery. Most of the emissions come from the production and supply of the medication itself. Partly this is due to the limitations of the footprinting methods, which are based on cost rather than detailed life cycle analysis. Thinking about how we might reduce emissions from patient and staff transport, this was part of our intravitreal project. In Wellington, many older people live in the Hutt Valley and Kapiti area, which is not close to our major hospitals. When we looked at the journeys that patients made for their injections, we could see that too many patients were travelling long distances into Wellington Hospital, often driving past an injection clinic to get there. So we need to make more effort to deliver injections close to home, which will mean scaling up our services in Kapiti and Ropara. Other ways to reduce travel emissions generally include reducing unnecessary visits hopefully using smart technology to calculate risk and follow-up intervals, maybe telehealth, and also facilitating access to health services using public and active transport. Around 15% of our patients were using public and active transport. I think we could make it much easier. The rest of our efforts to reduce emissions are mostly focused on reducing consumption, procurement. Our sustainable practice guides are really options to reduce waste and reduce cost, and they empower surgeons to push back against infection control or others who might impose wasteful rules on them. For example, this American paper on using multi-use bottles for perioperative medications was a big step forward. There are also spin-off campaigns to reduce post-operative topical antibiotics and improve surgical packs so that less stuff gets discarded unused. We're looking at reusable items as much as possible. Some phaco machines offer reusable tubing and cassettes, but they still advertise their fluidic performance and high cut rates rather than low running costs and low emissions. There are also some moves to automate the carbon footprinting measure, which again empowers and nudges clinicians to make the best choices they can. Anyway, I'll stop there and thank you for your attention. I really look forward to some discussion and interaction at the end of the session.